Okay, good afternoon, dear participants. On behalf of the Global Health Workforce Project, in partnership with the Royal College of Pathologists, National Postgraduate Medical College of Nigeria, the Aga Khan University in Kenya, the Ghana College of Physicians and Surgeons, as well as the Association of Laboratory Medicine of the UK, I welcome you to our first case report stroke review, which is going to be on hypercholesterolemia. And I'm using this opportunity to welcome everybody. As a background to our activity this afternoon, I want to say that hypercholesterolemia is fast assuming a public health issue, particularly in Africa. And studies have shown that prevalence of hypercholesterolemia is on the rise, shown that hypercholesterolemia is of high prevalence in Africa and generally in adult population in Africa. And this takes into effect for us to be able to have case detection, case treatment, and investigation strategy strengthened in order to reduce the risk of cardiovascular diseases in Africa. Some studies that was done in about 10 African countries have shown an average prevalence of about 52.8%. And to be precise, the pattern has always been increase in total cholesterol, decrease in high-density cholesterol, lipoprotein cholesterol, and low-density lipoprotein cholesterol. In Nigeria, particularly, the prevalence is between 60 to 89% in the population of diabetics, and this is known to be as high across all the zones in Nigeria. And the pattern is the same as was generally reported in the 10 African studies. In South Africa, the prevalence is highest in Africa, and it is between 76 to 94% in the general public. And the pattern here is mostly of the high triglyceridemia, particularly in the females. But most interesting is the fact that only about 16% of these cases are on treatment. Now, it is my pleasure to introduce to us Professor Dr. Charles Van Heijen, who is going to lead us through this case report and review this afternoon. And it is my pleasure to invite him to take over. But before that, let me just say that he's a very experienced teacher. After his education and training in London in medicine and pathology between 1967 and 1985, he has worked as a consultant chemical pathologist, senior lecturer, and clinical laboratory director in both Liverpool and Southport between 1986 and 2013. And since 2013, he has been volunteering for professional organizations in London and Cambridge. It is my pleasure, ladies and gentlemen, to invite Dr. Charles to please take the floor. Dr. Charles.
Thank you. Thank you very much, Professor Akande. That's very kind of you. And I'm really delighted to be able to contribute to this first meeting on looking at case reports to improve learning for chemical pathology. I think the whole idea of learning from a problem or a case report is a very good way to stimulate learning, because problem-based learning, leading on to lots of questions, or case report-based learning is a very good way to stimulate one's curiosity and then to learn about the subject following this initial stimulation. So perhaps I could just say a little bit about myself. I was fortunate in having some very good chemistry teaching at school where I first learned about cholesterol, and I went to school in Johannesburg and London before I went on to medical school in London. And during my medical training, I did an extra year in biochemistry because I'd had a special interest in the chemical basis of disease. And then after I qualified and was working as a junior doctor, I chose to go into chemical pathology as a specialty because of probably my background in chemistry and biochemistry and my interest in the biochemical basis of disease. So since having started in Liverpool as a consultant after my training, I went on to run a lipid clinic. When I first started there, I was thinking of I should do some sort of clinical work, and perhaps diabetes might be a good area to work in. But my colleagues in Liverpool felt there was a need for somebody to start running a lipid clinic. There wasn't any lipid service available at that time, and my background was very suitable for that. So I started that, and I've had about 25 years experience of working in clinics to deal with cholesterol, triglycerides, lipids in general. Now, the case I'm going to present is, I think, well, from my experience, is very unusual. This is the only case I've come across quite like this one. I've seen lots of examples of raised cholesterol and dyslipidemia and all sorts of other lipid disorders, both secondary to lifestyle as well as primary because of genetic factors. But this is one of the more fascinating cases from my own experience. So I hope you find this interesting, and I hope this will stimulate questions, and we can discuss that later at the end. So here we go. So if we start, it's about a patient who was first seen at Alder Children's Hospital in Liverpool. And let's go to the next slide. And this is an abstract of the presentation, but we're going to go through it step by step so we can move to the next one again. So this goes back to 1985, and it's about a girl, 7 years old, living not far from Liverpool, and she was not very as energetic as you would expect for someone of that age. And she was taken to see her family doctor, who examined her and noticed that she had a heart murmur, and also she had xanthomas on her knees, as you can see in this picture, as well as on her buttocks. So as a result of these findings, she was referred to the Children's Hospital, Alder Hey. So we'll go to the next slide. And they carried out a range of investigations, including lipids, and everything was normal except for the results I'm showing you on this screen here. Her total cholesterol was 18, which is exceptionally high for anybody, for adults, irrespective of age. That's an extremely high cholesterol. Probably for a 7-year-old, the reference range would be something like up to 5 or 6 millimoles per liter. The other abnormality was the apolipoprotein B, which was 3 times the upper limit of normal. And at that time, Alder Hey would measure ApoB as part of every lipid profile. They also had some information about her family, in that her mother's cholesterol was high and her father's was high, as shown here. So now I'm going to present this case at a national meeting in a few weeks' time. And the format of this particular meeting is that cases are presented, including a number of questions. And then the audience are invited to look at the choices of answers and pick out their choice. And the screen will then show which answers the audience is choosing. So if we go to the next slide, this is then the first question. On the basis of what information we have, what do you think is the probable diagnosis? So here you can see a choice of 4. Is it most likely to be homozygous familial hypercholesterolemia, or compound heterozygous familial hypercholesterolemia, or autosomal recessive or cytosterolemia? All of these are conditions which give you very high cholesterol levels. So before we look at the answers, I mean, homozygous FH is what it is commonly called if you have inherited 2 mutations from one from each parent. And it looks like this is quite likely. Compound heterozygous means that the mutations are not quite the same. You've inherited one from each parent, but they're not exactly the same mutations. So a true homozygous state would be where the mutation is exactly the same from the mother and from the father. Whereas a compound heterozygous condition would be where there's a slightly different mutation. So we will find out the answer to that as we go through the case. But on the basis of what we've got so far, the most likely diagnosis is either A or B. You don't really know about whether B is correct until you have got some genetics carried out. The other 2 conditions I've listed there, C and D, are very rare, much more unlikely than the first 2. So the phenotype, therefore, in this case, is that of homozygous FH, and genetic testing may show that it is what is being called compound heterozygous FH. Although the new genetic terminology is starting to use other wording for this, but we'll come on to that. So if we move on to the next one. Okay, so she was investigated at the Children's Hospital. And first of all, her murmur, heart murmur, was mid-systolic, suggesting aortic valve disease. And hence she had an angiography carried out. And it showed that there was narrowing not only at the aortic valve, but also in the ascending aorta above the valve. So on the right-hand side, you can see that the narrowing is in the aorta above the heart, above the aortic valve. So as a result of a number of investigations, she went on to have surgery to deal with this stenosis. So the next slide shows you the operation where the aortic valve is opened up. And you can see there is a lot of fatty tissue around there. But as they open it up even further, the next slide shows you that there was what was described as extensive atheroma in the ascending aorta. So you can see that the forceps there are gripping layers of atheromatous tissue, and it's being separated up to before they manage to remove some of this thickened atheromatous material to improve the blood flow as well as open up the aortic valve. So very extensive, very advanced atheroma for a child at a very early age. Moving on then, next slide. Following on from this, samples were sent to the lipoprotein research unit in London at the Hammersmith Hospital, where they had facilities to look at genetics and do other studies. And they looked at the genes that are known to be involved in the cause of familial hypercholesterolemia. They looked at the LDL receptor gene, which even at that stage was well known to have many mutations which might be responsible. And it is on chromosome 19. Shown here are also other genes on chromosome 1 and chromosome 2, which may cause high cholesterol, such as the PCSK9 gene and the ApoB gene. But at that time, not much was known about these other genes. So anyway, they found that she had inherited one mutation from her father on exon 10 and another one from her mother on exon 4. Moving on. And here is the family tree. And because the mutations are different, although they are on the same gene, it is being called compound heterozygous familial hypercholesterolemia. And here you can see the index case. The patient has a cholesterol of 18, and she has got the 2 mutations. Her mother and her grandmother both have high cholesterols of 9 and 10 millimolar. So they have quite a severe hypercholesterolemia. Whereas on her father's side, her father has a cholesterol of 7.8, and her half sister has a cholesterol of 7. So the mutations on her father's side are less severe than on her mother's side. Okay, moving on. Another investigation carried out at the Hammersmith Research Laboratory was looking at lipoprotein lipase receptor activity. No, not lipase, low-density lipoprotein receptor activity. It is known that the LDL receptor may be defective or may be non-functioning altogether. And to study this, a skin biopsy was taken from the patient, and fibroblast cells are extracted from the skin, grown in culture, and then they use radioactively labeled low-density lipoprotein particles to look at the uptake of the particles into the fibroblasts. And they found that in her patient's case, there was no activity, less than 2%. So that is what is called LDL receptor negative, or commonly called a null variant of this condition, as opposed to a defective variant. Okay, so now we know that she has got very little LDL receptor activity, and we know the genetics, and we know the severity. So she started at the age of 8. She was started initially on a fat-modified diet, and one of the very few drugs that was available at that time for children called Probucol. That drug is probably not used at all today, but at that time it was one of the few, and it did, at that stage, it made perhaps a small difference. The total cholesterol was down at 14 or so, having been 18 to start with. And then soon after that, at the age of 10, she was started on lipoprotein apheresis. You can see here in the photograph is a picture of another girl who is having that procedure undertaken. And this was carried out every 2 weeks, fortnightly, where blood is passed through a machine and a column extracts the lipoprotein particles. And then it needs to be repeated frequently, because the levels come down and then go up again afterwards. So her total cholesterol would fluctuate from as high as 9 down to 4 before and after apheresis. And then 2 years later, a new drug became available, simvastatin, which was added to her treatment and made some further difference. Okay, next slide. Nevertheless, at the age of 14, she was having problems with her cardiac function, and she underwent an aortic valve replacement operation, as well as coronary artery bypass grafting, which helped her in that her symptoms then improved. But even so, a few years later, she was becoming increasingly symptomatic. It was becoming more and more difficult to take any exercise. And after a further evaluation, the conclusion was reached that she probably would benefit from both a heart transplant as well as a liver transplant. And that this would need to be followed by lifelong immunosuppression to prevent immune rejection of transplanted organs. So she was then went over to the other side of the country in Newcastle, the Freeman Hospital, where they had a unit that could perform this very specialized type of surgery. So she had a combined heart and liver transplant, which is most unusual procedure, even in this condition. Next slide. Question 2. Well, obviously, she's going to benefit from a new heart because her heart wasn't working well. There was all sorts of difficulties in achieving a satisfactory cardiac function. But the next question is, how does a liver transplant improve the management in this sort of setting? And the answers given here is I've put together a range of options, how improvements might occur, but would it reduce the production of cholesterol and lipoproteins? Would it increase excretion of lipoproteins in the bile? Would it provide receptors, either LDL receptors or scavenger receptors? And you might then guess that this is a story to do with LDL receptors. And the answer, next slide, is that indeed the liver provides functional LDL receptors. About 3/4 of all the LDL receptors in the body are found in the liver. Others are found in skin fibroblasts and lots of other tissues and organs throughout the body. And these LDL receptors are shown in the sketch on the right, of course, are required to transport low-density lipoprotein particles from the bloodstream into the liver. Okay, next slide. After the liver transplant, her total cholesterol was now well controlled without any need for apheresis and on a very low dose of a statin, atorvastatin. So it was very easy to manage her lipid disorder with a transplanted liver. And she did very well. So over the next 5 years, she went on to finish school, and she trained as a nurse and qualified as a nurse at the age of 22. Having been sort of motivated to go into nursing, having seen much of what goes on in hospitals over the years for her treatment. So things went well, and at the age of 27, she had a daughter who inevitably has heterozygous familial hypercholesterolemia. It's also called obligate heterozygous familial hypercholesterolemia, because if you have this mutation, a separate mutation on each chromosome of a pair, then it's inevitable that your child will have one of those mutations. So the daughter had inherited the exon 10 mutation, which came from her grandfather, which is, of the two, was probably the better one to inherit. The other one was more severe, and this one not quite so bad. So moving on. When she got to the age of 30, she once again had symptoms of ischemic heart disease. And she was showing deterioration of liver function. Her liver function tests were abnormal, increasingly abnormal. And the conclusion was that she was suffering from immune-mediated liver rejection, an autoimmune process where the transplanted liver is exposed to antibodies that reject the liver, despite the use of immunosuppression. Hence, it was decided that she should have a second liver transplant. At this point, her heart function wasn't that bad, so they didn't think about another heart transplant, but a liver transplant was considered to be worthwhile to further improve her life expectancy. And ischemic heart disease at this point was dealt with by putting in stents in the coronary arteries, as shown in the illustration there, to improve the flow of blood through the narrowed arteries. Next slide. When she got to the age of 34, she was working as a nurse in a local hospital, and she had a myocardial infarct and a cardiac arrest. And being surrounded by medical staff, they managed to resuscitate her, and she recovered from that. And then following that, she was given a defibrillator implanted into the heart to prevent cardiac arrest in the future. She was given further cardiac stents. And at this time, they were considering whether she should have another major transplant. And the local newspapers had a story with giving a a lot of her details and photographs of her and her daughter, saying this is a remarkable mum facing the prospect of again having a transplant after suffering repeated heart problems. Moving on. At the age of 40, she had recurrent chest pains, frequent breathlessness. They did further studies and found on an echocardiogram that her heart was not working very well. The blood was regurgitating in the valves, and systole was not optimal, was very much reduced, it was impaired, and not much blood was being pumped the way it should be. And then at the age of 41, she was very sadly at home and she had a cardiac arrest, which was fatal. And partly it was fatal because the defibrillator didn't function at the time. So very sadly, she died at that age. Moving on. Next question then is, and I had been thinking that perhaps if they had been more aggressive in lowering her cholesterol at a later stage, they could have prevented further disease. And I thought that, why did they not give higher doses of statin to achieve lower cholesterol results? So that leads into the next question, is what pathology is causing her as cardiac symptoms at this late stage in her life and cause the cardiac arrest leading to her death? So is it likely to be atherosclerosis, which is what I thought was going on? I thought she started off with atherosclerosis, and I just believed that she was probably having ongoing atherosclerosis, and that if only her perhaps lipids had been better controlled, it wouldn't have progressed as the way it did. Or could it be a condition known as immune allograft vasculopathy, where there's an immune rejection of transplanted tissue? Or was she having infarctions, myocardial infarctions, or could it be endocarditis? Well, I discussed it with the transplant surgeon who had been looking after her. And the next slide gives you the answer, that he was convinced that what was happening to her was that she had developed what's called cardiac allograft immune vasculopathy, which is not the same as atherosclerosis, because atherosclerosis causes patchy narrowing of the coronary lumen, whereas this immune vasculopathy causes a much more diffuse narrowing of the lumen. And you can see on the right-hand side that luminal thickening is evenly thick throughout the lining of the artery. So this was happening in her coronary arteries and was leading to symptoms of ischemic heart disease and blockage of blood flow to the myocardium. Next slide. Now her daughter is now 16 years old, and the last results were that she was doing well on a low dose of pravastatin. LDL cholesterol had originally been 5 millimolar at the age of 8, which is higher than the reference range for girls of that age, and was now reduced on a low dose of pravastatin. You might argue that you should be using a higher dose of statin, and that's debatable. Perhaps you should be. Now, I've said that her mother had the phenotype of homozygous FH, but on genetic testing, it looked like you should describe it as being compound heterozygous FH. But there is now a new terminology is being recommended for describing the complexity of the genetics underlying disorders such as this. So the more fuller wording to describe what's going on is that it's monogenic, that is the LDL receptor gene. It's biallelic, it's inherited from both mother and father. It's semi-dominant in that both in the heterozygous and homozygous state, it gives you a disease with clinical features. It's related to LDL receptor loss of function, rather than gain of function. It's a null variant because there is no LDL receptor function, and it's hypercholesterolemia. So it's a very wordy description, but that would be the full wording to describe the condition that the mother had. Okay, next one. If you look at the website, Heart UK is the Hyperlipidemia Education and Research Trust charity in the United Kingdom. And they give guidance on a variety of lipid disorders, and they specifically describe homozygous FH, and they recommend that for children, the following treatments should be used. Apheresis, lipoprotein apheresis, from a very early age, if possible, and every week rather than every 2 weeks or less. From the beginning, you should start using a statin with ezetimibe, a combination to reduce the cholesterol as much as possible. And that for older children, you can use a new drug, the PCSK9 inhibitor. And that a transplant, as I described in this case study, is very much a last resort. The liver transplant is not curative, and particularly there are the complications of long-term immunosuppression and the possibility of immune rejection, as you could see in this case. So most guidelines internationally would say liver and heart transplant should be very much a last resort. Moving on. You might say, fortunately, there are now some new treatments becoming available. And the European Atherosclerosis Society latest report describes this new drug called evinacumab. And it is a monoclonal antibody which inhibits a naturally occurring protein shown here, ANGPTL3, which in turn is an inhibitor of lipoprotein lipase and endothelial lipase. So giving an injection of this monoclonal antibody leads to increased activity of the enzymes, the lipase enzymes. As a result of that, triglyceride-rich lipoproteins such as VLDL are broken down increasingly, and the lipoproteins that are produced from that can be removed by the liver through LDL receptor independent pathways. So this drug would be expected to work in somebody who does not have functioning LDL receptors. And if we look at the next slide, here is an example of another child with a very similar condition who was born in Pakistan and moved to Canada at a young age, was identified, diagnosis was made at an early age. And this shows the lipid results over about 15 years up to the present. And over the years, this boy has been on lipoprotein apheresis and various medications. And it's only in the last 2 years, you can see the introduction of evinacumab achieves desirable lipid levels. And it allows apheresis to be carried out once a month instead of once or every 1 or 2 weeks. So the new drug is not to replace the other treatments, but in addition to the other treatments, allows very satisfactory results. However, it is very expensive, and there are, it's not many studies have yet been done. Carrying on. The latest guidelines describe the global prevalence of homozygous FH as being 1 in 300,000, whereas previously it was thought to be 1 in a million. But now, looking at all the worldwide data, it looks as if it is more common than was previously thought, at about three cases every 1 million of population. And here you can see a world map showing how many cases it is expected there will be in various parts of the world. So in Africa, for example, there must be in the order of about maybe 4,000 or 5,000 individuals with this condition. In the United Kingdom, probably about at least 200 cases. And generally, less than 5% of these cases worldwide have been identified. And I would guess that in the UK, we probably know about perhaps about 20 cases, but the majority have not yet been identified. And I would guess the same would apply in Africa, that very few cases have been identified. And the vast majority are presenting with disease, advanced disease, probably later on in life. Moving on. So next question is that about the prevalence of this disorder. So we now know that the global prevalence is something like 1 in 300,000. But there are some populations which have a very high prevalence. And that would be because of a founder effect. Founder effect meaning that there are perhaps 1 or 2 individuals that carry the mutation. And because it's a fairly closed community, that they don't mix very widely with others in the community, that it is multiplied and the prevalence becomes higher. So I've listed here a few examples of populations, and the question would be, which of these has the highest? Now, the Pima Indians don't have this condition very much at all, and no increase anyway. They're particularly known for having a high prevalence of diabetes. French Canadians, Christian, Lebanese, and Afrikaners in South Africa are all known to have a considerably higher prevalence because of the founder effect. So that would be the French going to live in Canada, Christians living in Lebanon, and the Dutch migrants, Afrikaners, going to move into South Africa. And in fact, the highest of those groups is, the next slide, supposed to be, according to the data, is that the Afrikaners in South Africa have a 10-fold higher prevalence of this condition. And I thought this was a very attractive painting showing in the 17th century, when the Dutch settlers first arrived, the Cape of Good Hope, Jan van Riebeck, and they very much kept to themselves, as we know from the history. And of course, probably as a result of that, this mutation became more frequent in that population. Going on. So a few key learning points from my report are the following. First of all, we know the prevalence is higher at 1 in 300,000. It's characterized, homozygous FH is characterized by very elevated LDL cholesterol, typically above 10 millimoles per liter, and it causes premature disease, cardiovascular disease, even in childhood, if it isn't identified and treated early on. Most of the standard lipid-lowering drugs are only moderately effective. They make some difference, but not enough of a difference. And lipoprotein apheresis is, in general, the mainstay of treatment. And there is the possibility that new drugs, such as vinacumab, are going to be very effective in the future. And this drug has been approved in North America and Europe for children from the age of 5 years onwards. But the limitation is that it is extremely expensive. Moving on. So if you'd like to read more about this condition, I would recommend looking at this reference in the European Heart Journal, which is an open access description of the latest thinking on homozygous FH, describing the new treatments and guidelines. And here I've put in an infographic showing some of the main learning points that are described in this update. And you can see, for example, if you look at the event-free survival graph on the right-hand side, it compares high-income countries to non-high-income countries. And not surprisingly, if a country doesn't have a high income, it's less likely to be able to use treatments such as apheresis and new drugs, probably less likely to be able to use genetic testing, and probably less likely to detect this disease early on. So, not surprisingly, non-high-income countries have a worse event-free survival. Next slide. I managed to find an example from the literature of a case in Central Africa. And this case was reported last year, and it's about a young man from Uganda who presented at the age of 40 with triple coronary artery disease. He had symptoms and extensive or severe narrowing in the coronary arteries. His total cholesterol was 14, LDL cholesterol, no, total cholesterol 16, LDL cholesterol 14. And in his family, his mother had died early, but we don't know why. And 3 of his siblings have high LDL cholesterol. We don't know the figures for that. But interestingly, he had xanthomas at this age, but some of these xanthomas on his elbows and on his legs had been present from the age of 7. Now, he was treated with coronary artery bypass grafting, and he went on to medication with a statin and ezetimibe, which brought the LDL cholesterol down from 14 down to 4 millimole per liter. And the authors say that in Uganda, they don't have, genetic testing is not available. Some of the new drugs, such as PCSK9 inhibitors, are not available. And they have limitations as to how far they can take in treatment and investigations. So next slide. These are some of the photographs showing the xanthomas on the back of this person's hands and on the elbows. And because of because the xanthomas were present in early childhood, and because of the very high cholesterols, he fits the definition of homozygous FH without doing any genetic testing. So I think there we go. That brings my presentation to an end.
Thank you very much. I'm sure the participants have enjoyed the way the case was well presented, the questions that led to the various aspects of the presentation. I want to thank you very much, Dr. Charles, for that brilliant presentation. Now we have some few times for questions and clarifications. And at this point, I would like the participants to raise up their hands so that they can bring their comments as well as their questions. However, let me say that I have learned a great deal, particularly when you're talking about familial hypercholesterolemia. And because in our practice, we have seen more of the secondary hypercholesterolemia. And most of the times, we tend to co-manage with the physicians. So this case has been very, very interesting to me to see the scope of the team that managed the case and saw how this has moved from one generation to another, which is really about genetics of the disease. Again, I have seen that some limitations to our practice of lipidology clinic, particularly in Nigeria, and I'm sure it's by extension to some other African settings. Limitations being that we have limitations of genetic testing, supportive therapies such as the liver and the heart transplant like you mentioned here. And we have a very few range of anti-cholesterol drugs that are available to us. And if they are available, they are always very, very expensive for the patients to get across to, particularly when they are going to use for a very long time in life. So these have been some of the limitations to our own practice in the lipid. So I was saying that some of the limitations that we have in our own lipidology clinic practice included genetics testing facilities, supportive therapies like the liver and the heart transplants, as well as some of these anti-cholesterol drugs. And even when they are available, they are very, very costly for our patients. And this is definitely an eye-opener in the sense that you did say that the cases are more common than they were previously thought.
Yeah.
And one of your slides, you did mention that the Afrikaners in the South African even have the highest prevalence in the world. So
Yeah.
I'm sure this is, we will keep on looking in other parts of Africa. It might not be as high as the Afrikaners in South Africa. I'm sure the prevalence will be equally high in other parts of Nigeria. So I'm using this opportunity to call on the participants. I've not seen any hand up to ask questions from the presentation of this case. And I'm sure many of us are just getting to know or getting familiar with a case presentation of the familial hypercholesterolemia, particularly of the homogeneous genetic type. Okay, so we have some hands up. So I don't know if Dr. Shaz have access to the questions, or you want me to read the questions?
Well, if I go to the chat box, I can see a question, yes.
Please, can you go ahead? Just
Okay,
respond.
so, right. So the question says, it says, in the absence of genetic testing, can homozygous familial hypercholesterolemia be distinguished from compound heterozygous FH? Is there any difference in how they are managed? Okay, so a good question. It is now being recommended that the term homozygous familial hypercholesterolemia should be sort of a general overall term describing the phenotype without knowing about genetic data. And it's also being suggested that you shouldn't use the term compound heterozygous FH any longer, and that you are better using some of the new words such as biallelic or semi-dominant, LDL receptor related, and a more fully descriptive terminology. Up to about the last year or so, the wording compound heterozygous FH has been used to describe, once you've got the genetic results, that the two mutations are not exactly the same from the two separate alleles. Whereas true homozygous familial hypercholesterolemia genetically would be where you have exactly the same mutation from the mother and the father. That is the sort of thing that would be more likely to happen where you've got a founder effect in a population such as in the Afrikaners. Whereas in other parts of the world, you're more likely to have different LDL receptor mutations, and therefore it's more likely to be what was described as compound heterozygous. But when you come to the question of how they're managed, I guess it depends that the genetics might tell you about whether there's any LDL receptor function at all. So some of the drugs that are available require LDL receptor function. And if it is a null variant where there's no LDL receptor function, then some of the drugs will not make much of a difference. So the genetics will give you some idea of how you might manage the disorder. Is that okay? Then I've got another question.
Thank you very much. It's okay. That's another one. Yes, thank you very much for the response. There's another one from Dr. Ladoshu. I don't know whether you have seen that. It's talking about the availability and the cost of medications used in treatment.
Yes, okay. Yes, there are some side effects of this drug, but they're not that bad. The reports I've read seem to show that it's quite well tolerated and makes a difference where they have been able to use them in individual cases. There was originally some data comparing a placebo group to a treatment group in children, and I think the side effects were not a great problem, but there were some problems with that. I don't think the drug is available in Africa. I think even in countries like Canada, where I described a patient from there, the drug is not readily available, but they had a special arrangement where the company, I think, provided the drug because they could use the data as part of their research and publications. So it's even in high-income countries, the drug is not readily available. And although it's been approved for use in Europe, I don't think it's yet been recommended in terms of being cost effective. So we're waiting on that one. I think the costs are probably too high for them to be available almost anywhere in the world. And the dose of the drug, it's given by intravenous injection once a month. I don't know the exact dose, but it is only once a month. And when it is given that way, it would typically be given, perhaps apheresis would be carried out once a month, followed by the drug. And then you can have a whole month before the next treatment. So it makes life a lot easier for the individual and the healthcare team. But it's not yet at the stage where you say this is a major breakthrough in terms of the practice in the way things dealt with. But it's for the future, it might become more affordable.
Thank you very much. I think there's a comment just before the one you took. Yes.
Yeah. Next one is xanthelasma on the eyelids are quite common in our community, right? And many patients usually come to clinics to complain about them for cosmetic reasons, especially younger women. Should lipid testing be routine for such patients? I think so. I think yes. If they fit if they look like they are xanthelasma, then they may point to an underlying lipid disorder, not necessarily a severe one, but it is generally recommended that in this country, in the United Kingdom, that if you have any sort of xanthomas, or including xanthelasma, that you should do a lipid profile to see if there's something that can be managed further.
Thank you. There's this comment that we missed earlier on. I think the person is trying to probably get at what are the predisposing factors that could or that are responsible for the high prevalence of this disease condition in the Afrikaner of South Africa. And the person is trying to go ahead, please.
Yes, I understand. Why? So why is it more prevalent in Afrikaners in South Africa? And in fact, it is also a very high prevalence in Ashkenazi Jews in Johannesburg, I've discovered. This is what it is that people have migrated from other parts of the world, such as Europe, Asia, to parts of Africa. And some of these communities, such as the Afrikaners and the Jews in Johannesburg and Cape Town, don't mix with any other populations. They keep very much within their own population. They marry within their own population. So there might be cousin marriages in leading to children. And therefore, any mutation that does exist is more likely to go from being heterozygous to homozygous states. So it's called a founder effect, and it's to do with particular mutations that have been brought from somewhere else. So take the mutations that are most common in Afrikaners in South Africa. The same mutations are found in some parts of Holland, the Netherlands. So in Holland, they are not that such a high prevalence because the people who carry those mutations have mixed with others. But in those communities in Southern Africa, South Africa, they have tended to stay within their own communities, and the same would apply to the French living in Canada. and some other communities in the world.
Thank you very much, Dr. Chaz. For now, I haven't seen any more questions in the chat room. And the participants, we still have like some 20 minutes, so you can still draw in your questions into the chat room. So, but maybe I should ask this question myself. Dr. Charles, how willing will you be to help us with some of these limitations in our own setting? For example, we'd like to see what the current prevalence rate of this is in our country, because we want to start to look for more of these cases.
Yes. Okay, yes, I would be very happy to try and participate and give advice or my opinions on how you could investigate this, about whether you should be screening, at what stage you would want to do this. This particular reference I described does give advice as to what sort of screening is desirable in terms of identifying this particular condition, but also familial lipid disorders in general. And there are, well, I think they say things like, if there's a clear family history, then you should test the child as early as possible, at birth, soon after birth, in the first year, if possible. If there isn't anything in the family, then it's recommending that all children above a certain age, I think above the age of 5, should at some stage have a lipid test carried out, so you can pick up any genetic disorders. And probably they would recommend that if you have other factors such as obesity or diabetes, that all those people should have lipids measured as well. So it requires a bit of thought about how this can be used in practice, this advice, and whether it's feasible to carry out population screening in African countries, or what the facilities are. I don't know. But it's something that is probably, I would think, it sounds to me as if there's a lot of interest in identifying lipid abnormalities, dyslipidemias, because it's regarded as being it's now been found to be very prevalent. And if you can identify the most high-risk cases, then you can take very active measures to reduce the risk. Yes, I must say that I agree with you entirely. We're seeing many cases of young men of sudden death. I just guess that it goes on to say that probably we're not looking enough. And with this talk now, I think this is very, very stimulatory. And please, can you talk to us? And this is very, very important, because it might interest you that you're talking to young professional chemical pathologists who are just starting their career. And I must say that I know that many of them are interested in lipidology. Can you talk to us maybe for 5 minutes? How do you set up a lipidology clinic, if you don't mind, from your own experience? Yes, I can describe my own experience of that. Because, well, I suppose I was interested in cholesterol as part of my general studies, and but I didn't have an interest in lipids any more than any other part of chemical pathology. But when I started a consultant job in Liverpool, I wanted to become involved in some sort of clinical activity. And my first thoughts were that I had done some research in diabetes, and perhaps I might become involved in the diabetes service, participating in the clinics there. At that point, this is going to the 1980s, there's only one other lipid clinic in the northwest of England. And the colleagues in Liverpool asked me if I would start a lipid clinic instead of doing diabetes. So it wasn't my intention, but I was asked if I would do it at that point. So I went over to look at the other clinic in Manchester, the next big city, and saw how they were running it there. And then it took a fair bit of negotiating with my employer and other colleagues about how to start the clinic. And fortunately, one of the other specialists in diabetes endocrinology was very interested in lipids. And the two of us decided we could work together and start a clinic. So we managed to get approval and funding to start a clinic. And in the beginning, it was a very slow process. We had to draw up guidelines as to what sort of lipid testing should be done by family doctors or other doctors in the hospital setting. And then we had to draw up guidelines as to what sort of patients should be referred to a lipid clinic. So quite obviously, when you do lipid testing, you pick up a lot of very minor disorders, which don't require that much in the way of specialist treatment. They require just lifestyle change. They're secondary hyperlipidemias most commonly. But when things become more difficult, or when perhaps you need new treatments or combination treatments, or if it looks like it's an inherited family condition, then it's more likely that these people should be referred to a special clinic. So you need to have guidelines, you need to have colleagues who are supportive, and you need to know what is available in your own setting. So in Africa, for example, you know which drugs you can use, but you can't use all the other drugs which have become available more recently. You probably won't be able to do much in genetic testing, as you say, so you would have to go on the family history, which is pretty much what I did in the beginning. And the patient I've described who went on to lipoprotein apheresis, in my practice of 25 years of doing lipids, is the only patient I've come across with this condition. So it's not as if you're going to be have that as something to hold you up running a...
Thank you very much. There is a question. Are there established reference intervals for lipid profile in children?
Yes, there is data on that. It's not easy to find. Even when I was preparing this case study, it was quite a struggle to find a reference range for LDL cholesterol in young children. That sort of data is not much of it about. So it's a bit difficult with age-related reference ranges. And quite often laboratories, and the one I worked in, did not report the reference range, but would refer to guidelines and recommending the use of ratios between lipids to look at risk. So the question of reference ranges is quite a problem in lipid reporting.
I hope the participants have taken note of that, because we have this challenge mainly too in our clinic about this reference ranges for lipid reporting. Thank you very much. The next question is, what is the role of lipoprotein A in the management of this disorder?
All right, yes. There are more and more studies on this, and it is being regarded as an independent risk factor. And it is being recommended that you should use the measurement sometimes in particularly if there's families where that you would perhaps measure this if you couldn't explain what was going on in a family. Say you had somebody with, it looks like it's familial hyperlipidemia, but the lipids are essentially not that abnormal. Then you might look at lipoprotein little a as being a separate risk factor. And there are drugs which can be used to deal with that. I think it's not routinely measured, but there are situations where it may give you some further information.
Okay, the next question, if you don't mind.
You're welcome.
Charles?
You're welcome. I'm delighted to be able to explain things from a bit of information from my experience.
Okay, thank you very much. Now the question goes thus: in the absence of genetic testing and definitive treatments in our setting, what protocols can we adopt as a country? I guess this person is referring to Nigeria. Yes, this is from Nigeria.
Okay, so I think if you were to look at, for example, Heart UK, which is probably the main specialist group in the United Kingdom for lipids and advice on what to do about lipids, I think you will find guidelines there as to what you should be doing. And I think quite a big part of it is doing risk assessments. And they advise using risk calculators such as the Q-Risk version 3, which allows you to put in a whole range of different measurements, such as blood pressure, height, weight, smoking, other diseases and that. And it allows you to choose ethnicity as well. So one of the options is to choose Black Africans as one of the ethnic options. And you will find that if you look at white Caucasians compared to Black Africans, that Black Africans don't have quite the same high risk as white Eurasians have. So that comes into the calculation. So I think if you were to set up this service in your country, you could use the Heart UK guidelines on how to manage lipids and how to do risk assessments, and you would find that your guidance might be somewhat different. You would probably have to describe the drugs that are available and the ones that are not available, and that genetic testing may or may not be available. I think most of the time you can probably run a good service without doing genetic testing. And for most of the patients, you don't need to have that many specialized drugs. You're more likely to be able to want to use combinations of standard drugs.
Thank you very much. The next one goes thus. What is the relationship of hypercholesterolemia to high prevalence of erectile dysfunction among young men, which is seemingly recalcitrant to lipid treatment?
Yes. I think that is probably more of a problem with diabetes rather than with lipid disorders. I don't think hyperlipidemia particularly influences blood supply in that area. So I think hyperlipidemia is particularly related to cardiac coronary artery disease, and in some settings related to peripheral vascular disease and stroke or cerebral circulation. But it doesn't strike me, I don't think it relates in particular to erectile dysfunction. Is that right?
Yes, thank you very much. There's a question for you, and I think this is very, very interesting to me.
Yeah.
It says, what is your experience in running lipidology clinic vis-a-vis the role of the cardiologist?
All right, yes. Yes, I have found that some cardiologists and some people working with diabetes endocrinology have got us an interest in lipids as well. And some pediatricians have a special interest in lipids and metabolic disease. And that as a chemical pathologist, it would probably be good to work in collaboration with other specialties where there's an overlap in interest. So I started in the beginning having a joint clinic with another consultant doing diabetes, and we jointly ran a lipid clinic. And then later on, I got to know one of the pediatricians at the Children's Hospital, and he was very much in favor that we should have a clinic where we looked at the whole family, the children as well as the adults. So we managed to do that, had a clinic on that once a month where we would see families and look at the broader picture. So I think it's, well, if you say cardiology, yes, I mean, they do, quite often cardiologists are particularly interested in lipids, and they will often manage the more straightforward lipid disorders. But they find that when it becomes more difficult, when they need to use combinations with more follow-up, that they've got a lot of work just dealing with other cardiac disorders, and they'll appreciate having somebody with a special expertise in lipids to refer patients to.
Thank you very much for that response. And
yeah,
hello.
Yes, I'm here.
I think the last response from Dr. Charles overemphasizes the fact that you need to have a multidisciplinary team approach to your case management, just like we emphasized during our last webinar. So I think in developing your guidelines, you should put this in mind, that you need to work with other physicians as a team in order to have an efficient lipid clinic running. So
That's
thank
right.
you very much. The next question is this. Was insulin assay considered in the case presented? If so, any positive findings?
Did I hear that correctly? Was insulin considered?
Yes, was insulin assay considered in the case presented?
Oh, insulin assay.
Yes.
No, no, I don't think so. No. I know that for very high triglycerides, it may be useful to give insulin to reduce triglycerides, particularly if there's diabetes at the same time. But insulin does not really come into the treatment or assessment of familial hypercholesterolemia. No.
Thank you very much. Thank you very much, Dr. Charles, for your time. And I think I have a lot of chats thanking you for your time and for educating us on your experience.
Yes. I'd like to say thank you for giving me, thank you for the opportunity. It's been a very stimulating experience, and I've enjoyed participating very much.